I got an idea. We've seen this PBM industry from every side, and it isn't good. And it's certainly not good for the client.
If you're an employer and you're looking for a way to cut costs, you have to manage claims, manage the frequency and severity of claims. If you can do that, then you'll be successful in reducing your overall costs.
Thinking about that and what you said, I often will ask employers, do you accept 30, 40, 50% waste in your core business? The stakes are higher than ever in terms of who you hire to manage your benefits.
Are you sick and tired of the high costs and inefficiency plaguing our U.S. healthcare system? Do you feel like you're navigating a maze when dealing with insurance companies, only to end up paying a fortune for basic medical services? Then this Broken Healthcare podcast is for you. So get ready to take control of your healthcare. Here's your host, Ray Kober.
And we're live. Ladies and gentlemen, my name is Ray Kober. I'm your host. Welcome to Broken Healthcare. I'm thrilled to have with us our next guest, Renzo Luzzatti. Renzo is the CEO of USRx Care, a fiduciary PBM, or maybe not. We'll find out. But Renzo is someone that I've known now. How long have I known you, Renzo? It's been a minute, few years.
At least 5 years, maybe.
Right? At least.
Yeah.
We run in the same circles, and Renzo is passionate about the same mission that we're on here, which is to kind of expose healthcare's big lie, which is you can actually do something about the cost of healthcare. So, Renzo, welcome. Thank you so much for joining us. I'm thrilled that you're here.
Thanks, Ray. It's a pleasure. It's not usual that I'm all suited up here with the headphones and a microphone in my mouth, but I'm excited to be here, and thanks very much.
You look fantastic, and
right.
we are once again thrilled to have you. So I think let's just kick it off and level set, because our audience is quite diverse, and I think a lot of employers and decision makers that might come here, or maybe we have, folks on the front lines, employees that are just, trying to wrap their head around what's going on with the cost of healthcare. And I guess the just to address kind of the 3,000-pound elephant in the room, can we actually do something about the cost of healthcare?
Well, the answer is absolutely yes, but not in the traditional way. Right? Most employers are still working with one of the large carriers and one of the large PBMs to manage their benefit. And we know from 30 years of experience that has not produced sustainable savings.
Right. And so when you're saying carriers, obviously we're talking about large insurance companies like United Healthcare and Aetna and Cigna, et cetera, correct?
Correct.
Yeah. And so they are, for folks that have tuned in and listened in our listener base, they kind of hear me ad nauseum say that, yes, you can manage this, but it's very difficult when you're kind of playing by the rules of the game that they are set by the insurance carriers. And I think that's exactly where you're going.
Right, exactly. The game is rigged, unfortunately, to the benefit of the enterprises that are administering the benefit, right?
Yeah.
And at the end of the day, their obligation is to their shareholders, not to the client, unfortunately, right? If you're a large publicly traded company, you answer to one fiduciary obligation, and that is the shareholder. And in order to maximize the share value, you have to increase revenues, right, and increase profits. And unfortunately, the way that the industry has evolved, the more that the plan spends through the carrier network, through the PBM, the higher the profitability to the carrier and the PBM. Right, it's a direct conflict of interest.
It's crazy, right?
We're in this situation that we're in today, where we're surprised every year that costs keep going up. But it shouldn't be a surprise, because at the end of the day, revenues need to go up in order for the companies to continue to survive.
Right. And it's so the MLR, the medical loss ratio, which is built into the ACA when the Affordable Care Act was produced, Obamacare, as many people know it. The MLR states that for every dollar an insurance carrier takes in, they have to spend 80 to 85 cents of that dollar on care. And that sounds logical and reasonable. And everyone said, yeah, that sounds good. Until you kind of zoom out and you say, well, that leaves 15 to 20 cents. Where does that go? Well, that goes back to the insurance carrier for administrative overhead and revenue. And so to your point, Renzo, revenue has to go up. So if revenue has to go up, then what also has to go up? Claims have to go up. And so it doesn't take, a very sharp person to kind of put two and two together to say, if I continue to have my caboose hooked up to this locomotive, it's not going to go where I want it to go. It's going to go where they want it to go.
Right.
And our interests are not aligned here. So, take us back just a little bit. I like to ask my guests, no one finds, very few people that I've run into in this industry kind of grow up knowing that this is what they want to do.
Uh-huh.
I always joke, and I used to do a lot of recruiting in my position with Aflac as a regional manager, and we used to do group interviews. So I had a room of 50, 100 people because the demand was so high and the job market was so strong at one point. And I used to laugh, and I used to say, if we go to the local preschool and we ask the kids, we gather them around during circle time, and we say, okay, kids, who wants to be an insurance man when they grow up?
Right.
Or if we ask them, what do you want to be when you grow up? You're going to get fireman, you're going to get nurse, you're going to get doctor, you might even get lawyer, but you're not going to get insurance guy. So how'd you end up here?
It's a good question. So it was not a career that I really even knew about until late in life or really thought about. Growing up, I grew up in a household of nurses and doctors, and I thought I wanted to be a doctor. And I went all the way to spending a year in medical school. I was in New York City and at a great institution. I felt privileged to be there. But I realized that I didn't want to go in and out of examining rooms 40 times a day for the rest of my life. And I'm not diminishing the value that physicians provide. But for me, my head was in a different place. So I ended up actually spending a couple of years. I was in New York. I worked at an investment bank and was bored, to be honest. And I knew I needed to get back into healthcare. And so I went and got an MBA.
Wow.
I went to Wharton School and did healthcare and finance, and then started on the business side. Started in healthcare consulting.
Name dropper. University of Pennsylvania, Wharton School.
That's the one.
So I have to share this story with the audience since you brought this up. So when I'm an older guy now. When you have kids that are they're in high school, they're on the way to college. I don't even know if they do SATs anymore. I think they still do, but it's not counted. Anyway, we make the rounds, and I'm on the circuit going to different schools with my son at the time, and we get to the University of Pennsylvania. And so they do this orientation for all the prospective students and their parents. And the opening line is, our university was founded by Benjamin Franklin. Yes. I was like, drop the fucking mic.
His statue is on the campus.
As an opener, you cannot do any better than that. Right. I'm sorry, Harvard, you can't do better. Anyway, got your, sorry about that. I had to share that.
I started at Hamilton College, which was actually named after Alexander Hamilton, who was the original board of trustees. So,
excuse me.
Yes.
And so you got in the back door.
So I went from Hamilton to a Benjamin Franklin.
Wonderful. And so
anyway, I ended up working in hospital consulting and managed care,
Yep.
I spent a number of years in the pharmaceutical industry. That's how I got introduced to PBMs and rebates and all of that good stuff.
Yep.
And then I spent some time at WellPoint, which then became Anthem. So I was on the payer side. And our co-founder, Teho at our company, USRx Care, grew up also in hospital, but in managing pharmacy and pharmacy risk. He also worked for at-risk physician group practices. He's owned specialty pharmacies, retail pharmacies. Between us, we've pretty much done everything that there is to do in this space, including managing pharmacy risk. And in 2007, I approached him. I said, I got an idea. We've seen this PBM industry from every side, and it isn't good. And it's certainly not good for the client, right? And I think we have a better way. So we took our collective 25 years of experience each and took the best of the learnings from those years, and we built USRx Care.
Wow.
If I could just take a moment for those who may not be familiar with USRx Care, just to tell you a little bit about who we are and what we do.
Please.
So we are in the pharmacy benefits industry, but we are not a product of the PBM space. We came out of the healthcare or the health plan side of managed care. Think of a director of pharmacy at United Healthcare or Humana or Blue Cross, Centene back in the day when they had 2 million Medicare, Medicaid, and commercial lives. That's where we grew up, managing pharmacy risk for at-risk lives, upwards of millions of lives. When you're in that environment, there's a couple of things that happen. Number one, you get very clinically oriented, really deep on the clinical, because you have to get that right. The other thing is your part of your job is to be fiscally responsible.
Well, wait a second. So unpack that for me.
Yeah.
Why do you have to get that right? And is that necessarily gotten right in, let's say, a fully insured plan where you have one of the companies that you mentioned, running point?
Well, unfortunately, what we see is the level of clinical rigor that you have when you're managing risk is very different from the level of clinical rigor that you see when you're managing somebody else's risk, right? I mean, one of the things, if you're in a health plan and you're managing your own risk, one of the things you cannot do is take your claims and put them on an invoice to have somebody else pay at the end of the month, right? Which is what happens in self-funding with the carriers and the PBMs. You own that, right? You're collecting premiums, and then your costs are your costs. So one of the greatest levers of cost management is in the clinical. Everyone is chasing discounts and rebates, right? And that's where the industry is kind of focused, particularly employer groups. Well, even the health plans, what's the discount? What's the rebate? But we know from experience now, again, 30 years in the PBM industry, that the differential between PBMs and health plans in that area is not high. The market is mature. Everybody, for the most part, is in the same realm. But if you want to make a difference in cost that's 20% less, 30% less, 50% less on a PM basis, you have to do it in the clinical realm.
On a per member per month basis.
On a per member per month basis.
On the clinical side of the house. So it's not something that is, I'm not going to say easily done, but this is what you're describing is not baked into the processes of every PBM.
Correct. And even PBMs that should be good at the clinical, we find that the inherent financial conflicts of interest tend to get in the way, right? And we can talk about this a little bit later. Like, what's the most important, if you were to ask me, what's the most important thing that an employer can do to right the ship? And I'll focus on the pharmacy benefits.
Hey, Renzo, what's the most important thing an employer could do to right the ship?
That's a great question. And really, the number one thing is to deconflict their PBM relationship, right? And what do I mean by that? So let's talk about the PBM contract for a second. This is probably the least read document in the history of documents, right? I mean, if you're in a room of HR professionals,
except for the iPhone agreement,
that's probably the second. That's cool. But if you're in a room of HR professionals and you ask for show of hands, how many have read their PBM contract Out of 100 people in a room, you might get one hand,
Yeah.
right? But this is the document that governs everything that happens in terms of the management of their benefit, right? If you were to ask how many of them had an independent legal expert review their PBM agreement, you might see another couple of hands, right? Somewhat surprising, but I think part of it is inherent in the assumption that they can't change it even if they wanted to,
Yeah.
right? And it's too complicated; they don't understand it. But I always recommend, and if it's a broker or advisor and they're in meeting with a client, or if you're an employer that has hired a PBM, take the time to look at your PBM agreement. Just take a couple of hours and skim it.
And
There are some,
Renzo, like we're talking about, so, just to put it into perspective, folks, we're talking about some health plans in large organizations run into the billions of dollars, right? That's their cost. If you're an enterprise employer, your costs can go into the billions. If you're, large employers, your costs could be in the hundreds of millions or tens of millions. And RX spend typically represents 20 to 30% of claims on average. So you're talking about a significant amount of money. And yet most employers are just, they're of the mind, as Renzo said, as you said, Renzo, of, hey, there's nothing that could be done here. But and these same employers, scour the earth for turning over every rock they can to find savings somewhere. These are meaningful dollars, and it's as simple as them really, if they don't have the wherewithal, hiring someone or partnering with a fiduciary partner like USRx Care to review this document.
right, 100%. And thinking about that and what you said, I often will ask employers, and it's a little tongue in cheek, but do you accept 30, 40, 50% waste in your core business? No. If there was a operations VP that was running a division of a company and there was 30, 40, 50% waste in their cost structure, they'd be fired.
100%.
Right? But when it comes to healthcare, somehow the equation is different, and it really shouldn't be. It should be treated just like any other line item in the company. And there is so much waste, particularly in the PBM side of things. And literally, I mean, if you were to just take a look at a contract, look for some very basic things, such as look for a paragraph, for example, that says that the PBM is not a fiduciary and not obligated to act in a fiduciary manner. I think you'll find that in pretty much every PBM contract. Because they don't want to have anything to do with fiduciary duty, because their fiduciary duty, again, is not to the client, it's to their shareholder.
But
Right?
let me ask you, Renzo, maybe I'm putting you on the spot, but you have a contract with your clients. Does your contract name you as a fiduciary?
It does.
It does.
It does. Right. And for us, that's a game changer. And for the industry, it's a game changer. And this really kind of dovetails in with the Consolidated Appropriations Act, which hopefully every healthcare advisor and self-funded employer is familiar with. If not, talk to your consultant or go online and familiarize yourself. This was a gift to self-funding. This came out of CMS and the Department of Labor. It was an attempt to rebalance the power and shift power away from the vendor, away from the PBM, away from the carrier, back towards the employer. From our perspective, from my perspective, the industry that was charged with managing the benefit had way too much control over every aspect of management of that risk, where at the end of the day, it's the employer that's paying the bill, right? If I'm the client, if I'm the employer, I should have, I think, some say in terms of how my benefit is being managed and what are the levers that are being pulled, and what's the type of vendor that I'm hiring to manage that benefit. So you mentioned, the fiduciary. Yeah, we put fiduciary in our contract, and we hold ourselves to that standard. Not everybody is that familiar with what it really means to be a fiduciary, though. So fiduciary is a term that is defined by ERISA. It's a legal term. It has legal meaning. And there's three main tenets to a fiduciary. Number one, no conflicts of interest. Think about that. No conflicts of interest, right? Makes sense. Number two is only looking out for the best interests of the plan and plan participants. And number three is all utilization and financial information is in full view, which is transparency, in other words. So I'm often asked, is USRx Care a transparent PBM? And I say we are, but that's only one of three elements of being a fiduciary, right? There's two others: no conflicts of interest and only looking out for the best interests of the plan participants.
Mm-hmm.
So if you then think about the traditional PBM contract, for example, that has a paragraph in there that says the PBM is not a fiduciary and not obligated to act in a fiduciary manner. And some of them say that if you have a member in a state that requires a PBM to be a fiduciary, they can either not service that member or cancel the contract, right? That's pretty far from a fiduciary obligation, right?
Yeah.
So if I'm an employer and I'm signing that contract, everybody at the table has an understanding that the PBM can have conflicts of interest. They don't have to look out for the best interests of the plan and plan participant, and they don't have to be transparent. And at the end of the year, everyone's upset. They can't get their data, their costs are up, everything's a mess. You sign the contract.
Yeah.
It's right in the contract.
Yeah, and I'm in meetings all the time with folks that have gone down the path of self-funding, and they are feeling pretty good about themselves and where they are as an organization, but then they're self-funding and they're riding on the chassis of the BUCA, the acronym for Blue Cross, United, Cigna, et cetera, and the PBM is owned by the BUCA, and so
In many cases, yeah.
and not in all cases certainly, but in many cases. And they're attached to. Now, look, folks, there are different flavors and variations of being, and I hate the term self-insured, but that's the term that we have. Self-insured, self-funded, level-funded, lots of different ways to say the same thing. But the term self-insured, in my mind, implies risky. And what we're describing is not a level of risk. It really is a funding mechanism. And when it comes to your pharma spend, if you're with a UMR, for example, which is a division of United Health Group, United Healthcare, you could bet that they're making decisions with respect to dispensing your drugs that are not aligned with your best interests. Would you agree with that?
100%. And again, it comes back to the contract. I mentioned a paragraph that everyone should look at to see whether or not their PBM or their carrier, their TPA, is aligned with their own fiduciary duty, right, as a plan sponsor. But look at some of the definitions, right? How is a brand and generic drug defined? Because there's all kinds of pricing terms and guarantees that may be dependent on those definitions. Often it's up to the individual PBM to decide what it means, right? I mean, we've heard egregious cases in the past, large employers where at the end of the year, the reconciliation is being done on the prices that are being charged for drugs. And all of a sudden, 9,000 claims that used to be considered brand are now considered generic, right? They're moving it's really the largest game of three-card Monte or the shell and the P game that you've ever seen, right?
Yeah.
And good luck finding the money, right? Because you think it's over there. No, it's been moved over there. Oh, we'll tap that down. No, now it's over there. I mean, it's unbelievable. But
how many pages is it? How many pages is a typical contract?
Right. So look at the brand generic definitions. Everyone is chasing rebates still, which years ago I met someone at a conference and we were talking about rebates, and he described them as fool's gold. Fool's gold. And I thought that was a great way to describe it, because it looks all nice and shiny. But if you really get into it, in order to get a rebate, it's like using a coupon at the grocery store. You pay full price and then you use your coupon to get a discount. But the discount is always a percentage of the full price. right? So if I'm chasing rebates as an employer, and I lock in the PBM to guarantee a certain rebate yield, now me as a PBM, I have to run up a bill high enough in order to generate enough rebate or manufacturer discount money coming back in order to meet that guarantee. Right. So this is a really hard concept to get employers to understand. And even a lot of the consultants still are stuck on rebates. Well, what's the rebate? What's the rebate? And at the end of the day, again, if the more and the higher the rebate guarantee, the
Yeah.
higher the spend has to be for that plan, because you basically need an insurance policy. You have an insurance policy that needs to be funded. And how do you fund it? By spending more money.
Yeah. Yeah, I think what it really boils down to is common sense. You know, you need savvy finance professionals to look at it and say, look, rebate, schmebate, cut the rhetoric. What's the net? What's the net cost? What's the net cost to my plan? And I don't think it's that hard to figure out, right, Renzo? If I'm an employer out there, and let's say I'm running a good sized business, and I don't know, our revenue is $100 million a year plus, and we're spending $10 million on healthcare. By my math, actuarially, 10 million, 8 million of that, 10 million is going to be claims. That's where the money is. If you're an employer and you're looking for a way to cut costs, you have to manage claims, manage the frequency and severity of claims. If you can do that, then you'll be successful in reducing your overall costs. And when you break it down as a supply chain, we know that 20 to 30% on average is going to be pharmacy spend. So, in this scenario, what do you have? $2.5 million in RX spend in a $10 million spend. If 50% of that is waste, I mean, what could you do with that kind of money? Give it back to your employees, reinvest in other important initiatives. The list goes on, but you have to at least open your eyes and be open to the concept and be smart enough to ask the right questions, which is, well, how exactly are you arriving at a rebate? And I don't know, does USRx Care play in the game of rebates? Do you rebate your clients? Or how is it possible for little old you to compete against Express Scripts, Renzo?
Right.
How could you? It can't be possible.
It cannot be possible.
I am saying it right now, sir. You are a charlatan.
Well, let me prove you wrong. So it's interesting. We do a lot of quotes, right? So we get a claims file and we're asked to do what's called a repricing, which means that we'll take those historical claims for a client, we'll run it through our pricing tool and say, so for every claim on the data service, for the quantity dispensed for a particular drug, and use a drug code called an NDC, what would it have cost if we had adjudicated the claim as opposed to whatever PBM adjudicated that claim, right? And we run quotes against the big three all the time. And often we come out lower cost. And how is that possible? Because to your point, I don't believe that our pharmacy contracts have better rates than a CVS, for example, or an Optum, or a United, or Express Scripts. I'm sure, given their size, that they can command a better price, a bigger discount.
You would think.
But I know that we're passing on 100% of our discount, right? Our only source of revenue is administrative fees. There's a concept in the PBM industry called spread. And this is why often we come out lower, and those that should have a better discount at pharmacies may come out higher, because the amount that they charge the plan sponsor is more than they're paying the pharmacy themselves, right? So if I have a contract with a pharmacy that says, okay, for this particular drug on this day, I owe you $20. And then I turn around as a PBM and sell it to my client at $100, I've made an $80 profit margin, right? But that also means that the discounts that I get at the pharmacy are not being passed on completely to the client, right? So that's spread pricing. So in our world, the amount we pay the pharmacy is exactly the amount that gets invoiced to the client that is the plan sponsor, right? No spread pricing. So when I pass on 100% of our discount and compare that to a marked up price coming from another PBM, often we come out better. Does that make sense?
100%. And so essentially what it boils down to is pharmacy RX is a major profit center for insurance carriers who own these PBM units. I believe Optum RX is the biggest profit center in United Healthcare's business, right? And we had a situation where CVS bought Aetna, right? So you have an RX company buying a health insurance company, and if that doesn't open your eyes to the fact that there's a lot of money in the game, I don't know, what would. So let's shift gears for a second. There's a lot of talk going on right now, a lot of controversy, hype about obesity drugs and the obesity epidemic, and I guess the question as it pertains to your health plan. So if you're not in the category of being overweight, obese, morbidly obese, or a diabetic. Well, let's leave diabetics aside for a moment. But if you're using this as a weight loss drug, I guess the moral dilemma or the moral issue is, well, why should all of the members of your plan bear the burden of the cost of this drug if you have a weight issue, but you don't necessarily have a health issue? Not that being overweight or obese isn't a health issue, but let's say you're on the borderline and you're not quote unquote obese. You just want to lose a few pounds. Should you be able to access this drug through your plan and just pay your share of the cost? And I know that you probably are talking ad nauseum on this subject, but you're an expert, and so I'd love to hear from you. Where do you weigh in on the moral issue, and where do you stand as a business professional and someone who's running a business that is essentially in the middle of the manufacturer and the patient in getting these drugs distributed?
Yeah. So and you're really talking about the class of drugs called GLP-1s.
Yep.
Ozempic, Mounjaro, right? And the weight loss versions, Zepbound and Wegovy. I'm going to start off, and this may sound contradictory, but I'm
going to piss some people off, Renzo.
Yeah. No. I'm going to make the manufacturers happy.
Okay.
So these drugs, particularly the more recent entrants, because there were some others that have been out there for several years that are not as effective. Right? It's really when Ozempic and Mounjaro came to market that it truly revolutionized diabetes care and opened up doors for weight management. So the reality is that both of these drugs are game changers for many diabetics, truly game changers. And for individuals that are struggling with weight, they are very effective, very effective. The problem is they're expensive.
Yeah.
Right? And the demand is almost limitless, right? So it's really a potential train wreck situation for a health plan sponsor, right? So how do you deal with that? Well, a couple of things. When it comes to diabetes, and I'll focus on diabetes, not everybody should be on a GLP-1, right? So how do you police that? How do you make sure that only the individuals that can benefit have access to the medications? The number one route is through something called prior authorization, where there's a clinical review that takes place to determine whether or not this is the right drug for a particular patient and at what dose.
And now, does your organization do that, or is there another? You do that. Okay.
Yes. And we
So
should come back.
you're not relying on the services of a nurse, a registered nurse, or there are some plans that have concierge, medical management built in. What you're describing is not that. This is something that your team does in house.
Yes, we are very clinically oriented as a company, and at some point, Ray will come back at the end, and I want to highlight kind of again what we do as an organization. But
Yep.
because we've kind of gotten into it, but what we've seen in the marketplace for GLP-1s, particularly looking at some of the more established PBMs in the industry, is that conflict of interest, that disincentive, the incentive to dispense over cost control, has crept into the GLP-1s. And what do I mean by that? So let's talk about diabetes. The treatment guidelines that we see are being implemented by many PBMs out there are limited and weak to be kind. They may or may not require a diagnosis of diabetes. If they do, it's maybe based on attestation. Well, the doctor says they're diabetic. Whether they are or not, nobody knows, right?
Got it.
And I don't want to say physicians look to game the system, but sometimes they know if they fill out documents or provide information to a PBM with certain criteria, they know they're going to get it approved, right? So the PBM may or may not know if they're diabetic. If they are diabetic, they're not looking at a marker called hemoglobin A1C, which is a marker of long-term glucose control. They may or may not be looking at prior medication therapy that's been tried and failed, right? And in most cases, they're definitely not looking at the medical record. And why would you look at the medical record? So by contrast to USRx Care, we look at the medical record on every case. We'll take an attestation from a doctor, but then we'll look at the medical record to back it up. And unfortunately, fairly often, what is stated to be the facts is not necessarily the facts.
Well,
Right.
so let me, I don't mean to interrupt you, but so let me ask you, and I don't know if there's a correlation here or not, but, erectile dysfunction drugs, they're advertised all the time on TV. I can't turn on, Instagram or any one of the social media platforms without, just kind of being bombarded with this stuff. I don't know if it's my age, my profile, my demo. I don't know what it is, but it's everywhere. And so they basically say it. You don't need to, see a doctor. You answer some questions, and boom, we'll mail it to you. Are we talking about the same thing at play here?
It really is very similar.
Very similar to that.
Because at the end of the day, remember that the more the plan spends, the more the PBM makes in the traditional model, right? Not in our model. Again, we only get paid by a flat administrative fee. I don't make more money on a $2 drug than a $100,000 drug.
Yep.
Not in the business of selling drugs to members.
Right.
Often, people will say, oh, the PBM industry, it's so difficult, it's so opaque, I really don't understand it. The simplest way to think about the PBM industry is your traditional PBMs are in business to sell drugs to plan participants at a profit. If you understand that, they are selling drugs. They are in the business of selling drugs.
Sure.
For every drug that goes through the system, they have figured out 14 different ways to make a profit off of each of those transactions, 13 of which you'll never know about, right?
Yep.
And that's by design. It's designed that the buyer, the plan sponsor, doesn't know what they're paying. They certainly don't know how much the PBM is making off of each transaction.
Yeah.
Right? That's a recipe for disaster. What other industry does that occur? Nowhere, right? But in healthcare, because it's potentially an emotional thing, and you're talking about somebody's life or their quality of life.
Yeah.
A lot of the normal tenets of economics tend to go out the window.
Right.
right?
No, and I could tell you from personal experience. So I've had gout now since my early 30s. I think it's hereditary. And over the course of the years, I've been on, a number of different plans, and you have mail order. And I know at one time, I had a stockpile of this stuff because they would auto ship it.
Yeah.
They had to know that I didn't need it if they were tracking it properly. They had to know, because I have to tell you, I had bottles and bottles and bottles of this stuff, and it was just out of control until, I finally called them and I was like, what are you guys doing? But that's me personal. It's one example. If you're running an organization with dozens or hundreds of or thousands of people, and this stuff is going on in the plan because it can, who's policing this stuff? And I think the answer is it's not being policed. It's being encouraged.
That's right.
This type of stuff in a normal plan. I hate to say it, but that's what's going on. And the reason that I'm so passionate about what I do is it's infuriating to me, because this is food out of the mouths of your children. If you're a lunchbox Joe, you're an everyday worker, you're someone that, and I don't care what you make $250,000, you're probably spending $250,000 M1. If you're making $500,000, you're probably spending $500,000 M1. Right. These are meaningful dollars to everybody, but particularly for those folks. Like I think I've shared with my audience, my mom lost 2 husbands. Her childhood sweetheart when she was 26 remarried my dad. My dad was diagnosed with lung cancer, and he passed away when he was 40 years of age. And so she raised me and my 2 brothers single-handedly. Think about someone like that is doing everything in their power to put food on the table, keep their head above water, take care of your children, and you have these sons of bitches that are just, drowning you because, the shareholders need to make more money. And that's really what it is.
Yeah. And it's I want to say it's kind of evolved into where it's at slow enough, maybe, that the industry didn't see it coming, or couldn't put their finger on what the underlying issue or cause is. But I do feel, and I don't know if you feel it also when you talk to folks every day, that we're at or close to a tipping point. Particularly when it comes to the PBM industry. I mean, there's been so much written over the years about PBMs and the overcharging and the conflicts of interest and the overshipping on mail order, like you said, all of that stuff. But it just seemed to fall on deaf ears.
Yeah.
But I think with the increase in specialty pharmaceuticals coming to market at $200,000 a year, $500,000 a year, $1 million a year, $2 million a year, that escalated the level of pain within plans to the point where they can no longer just sit back and accept the status quo without asking some questions.
I hope you're right. I don't know that I share your sentiment. And I say that kind of sadly, but I just recently had the honor of interviewing Dave Chase, and he's one of the founding fathers, I think, of the battle against the status quo of healthcare. And he did a TED Talk that you can see out there, and in his TED Talk, he flashes one of his slides on screen, and it says there are 3 trillion reasons why healthcare is the way that it is. Mm-hmm. And fast forward to 2024, and we're projected to spend just under 5 trillion. And so folks like you and I and Dave and the people that are in the circles that we run in, look, you're not a charitable organization, neither am I, neither are any of the folks that run in our circles, but I think we're on the side of good, meaning you are a transparent PBM. You do show your clients exactly what the cost is and exactly what your administrative fees are in very much the same way that we do. And so I think the challenge that I have is most brokerages, most healthcare consulting agencies, most PBMs are not cut out of that cloth. And I don't, begrudge anyone. I'm a capitalist through and through. I don't begrudge anyone from earning a profit, but don't do it on the backs of working Americans, and especially don't do it where you're not giving them access to all the information, and it's kind of hidden. And I guess if you're tuning in and you are a decision maker with respect to procuring healthcare for your organization, ask questions, demand transparency. It's not that hard. And to be able to go to a company like Renzo's and share what your expense was and have his organization be able to do a side-by-side comparison to show you, okay, this is what you paid, this is what you would have paid, here's the net difference. Why the hell wouldn't you do that? It blows my mind that people would be resistant to that exercise when, and look, that's the tip of the iceberg, right? If he could show you, 30 to 60% savings in your RX spend, where might there be other opportunities for savings? And if you're, someone who's on the front lines that is one of those people that are in the open enrollment meeting that is hearing increasingly worse news every year, that you're going to have to pay more out of pocket for your health care. And by the way, when you go to utilize your health care, you're going to have to pay more money before you're even entitled to any health care. If you're fed up with that, this is what's going on behind the scenes. And there are professionals who are out there who can assist and actually give you, believe it or not, a course to $0 out-of-pocket access to healthcare. We do this every day for our clients. I'm not here to beat the drum and say, hey, come and see me. Go and see one of the many organizations that are out there like me. Go to an event like Rosetta Fest that's coming up in September and learn from the folks that are there. What we're talking about is not conjecture. This is stuff that we do every day.
I agree completely. And I do see an increasing number of employers that are going to their consultants and telling them, you need to find a different solution or I'm going to find a different advisor.
Yeah.
Right. And at the end of the day, that's what it comes down to. If I could challenge every employer in America that is either fully insured or self-funded, that is a sponsor of their employee health benefit, I would challenge every one of those individuals to call up their broker advisor and say, I would like our pharmacy benefit spend to be half per member per month next year compared to this year. Find me that path. Show me that path. And if the broker advisor says it can't be done, you might be talking to the wrong broker advisor. Because there's plenty of folks like you, Ray, that you said do this every day. But they're working with vendors like USRx Care that take pride in taking a fiduciary role, right? So we're on the same side of the table as our client, as opposed to the U.S. versus the Russians, where you're always on opposite sides of the table, and you know that neither of you have the other's best interests in mind, right?
Yeah. It's really tough because I think the one, if I had to describe it in one word, the reason that there's resistance is fear. Mm-hmm. People are afraid of change, and it's easy to just kind of do the same thing, right? If you're walking into a renewal meeting with your broker and they show you, oh, great news, we got no increase this year, we're flat, I think the temptation is to just kind of go along for the ride, right? You have a stack of other things on your desk that you have to get to. You have a zillion emails that you haven't opened. This is great news. Let's move on to the next thing. But if you really kind of boil it down and distill it, is that the best way to manage your business, right? Just to say, oh, we're good? Or, I don't know, might you want to get a couple of quotes, talk to some
Get
people.
a second opinion. We know
Get us.
in healthcare, the second opinion is one of the most valuable things you can do, particularly within in oncology, right?
Yeah,
So it's very much the same here. Maybe you should get a second opinion. There's some basic questions that plan sponsors can ask. And again, I work in the PBM industry, so I'm focused on pharmacy. But things like, are there any conflicts of interest in your PBM's business model? Right? Do they make more money when your costs go up? That's a direct conflict of interest.
sure.
Um, do they require that you utilize their pharmacies for any aspect of care, for specialty pharmacy, for mail order pharmacy? If so, they've eliminated any competition, right? That you don't have access to the lowest available cost if they're not the cheapest, right? And again, it's a direct conflict of interest. If they're looking out for your best interests of a plan, does that in some way negatively impact the profitability of the PBM? Right? I mean, these are just some basic questions.
Yeah.
And if the answer to any of these questions are yes, this does exist in my PBM relationship, then that's a pretty good signal that you need to start looking to change the dynamic of your PBM. And there's really two primary ways that employers can do that. One is to change your PBM, right? And seek to work with a PBM that has directly aligned interests expressed in their contract. In the case of USRx Care, we take it to a fiduciary level, as I mentioned before, right? We put the definition of a fiduciary in our contract and we hold ourselves to that standard. It is a legal term. You mentioned the term transparency, and I mentioned earlier on in the segment, fiduciary has three things: no conflicts of interest, only looking out for the best interests of the plan participant, and all utilization and financial information is in full view, which is transparency. So transparency is a necessary component, but it's one out of three. We don't believe transparency is enough. There's a lot of PBMs that have come into the market, transparent PBMs. Even the large PBMs are now coming out with a transparent model. But you can be transparent and conflicted. What do I mean by that? You might offer pass-through pricing where there's no markup on the drugs, meaning that whatever is paid to the pharmacy is what gets passed through to the client. But if 70% of your profits come from dispensing specialty medications, right, and you're requiring the client to use your mail order pharmacy, you've got an inherent conflict of interest, which can escalate cost, escalate utilization to the betterment of the PBM at the expense of the client, even though everything is quote unquote transparent. You'll never know what the margins are at their pharmacy.
Yeah.
Right. So transparency from our perspective is not enough. I mean, we've seen transparent PBMs that keep rebates. You can't keep rebates. You can't take a payment from a drug manufacturer. That's a conflict of interest. Why? Because drug manufacturers make payments to PBMs with an expectation of a return on investment. Right? I worked in the pharmaceutical industry for 8 years. We paid PBMs a lot of money, and what did we expect? Better positioning on the formulary, weaker treatment guidelines, maybe no prior authorization at all, right? We have a client that we took over from a large PBM, and we found out, and they found out in the transition, that their PBM wasn't doing any prior authorizations on Humira at all. This is a $60,000 drug. How's that possible? Because the drug manufacturer was paying the PBM not to do a prior authorization, right? So as a PBM, to eliminate all conflicts of interest, I can't take monies from the manufacturer. That doesn't mean I don't collect rebates. 100%, you want to collect every rebate dollar you can, but it goes back to the plan sponsor because it's their money, right? It's their coupon. They're the one that are paying for the drug. Why should I be getting money from a third party and keeping it myself?
And who's the plan sponsor, Renzo?
What's that?
Who's the plan sponsor?
The employer.
The employer. The organization that sponsors the plan is the plan sponsor.
Yeah. So, the whole rebate equation, I wish rebates would go away. There's been a lot of talk about that. I don't think Congress is going to get in the middle of that. And I'm not even sure, employers hate to pay rebates, and they blame PBMs and their thirst for ever more incentive payments from the PBM to prefer the drug and all that for driving up costs. But at the end of the day, from a manufacturer perspective, one thing that rebates does is it allows you to segment the marketplace and charge a different price and capture different profit margins in different segments of the business, if that makes sense. So
100%.
If I have to give more rebate dollars here to keep the business, I'll give it there. But if I don't have to give it to the other guy, then I'll keep that money to myself, right?
The answer is money, folks. What's the question?
Right.
Right? So you shared a lot with us, very insightful. What I'm hearing based on our conversation today is if you are an organization that has one of those logos on your ID card, one of those big insurance carrier logos, and the RX is being funneled through their channel, their PBM, which is wholly owned by them, a subsidiary of theirs, you're paying too much for your drugs. And how much more are you paying than you should? Probably, if you had a ballpark, it's certainly upwards of 20%. And from what I've seen, typically it's closer to 50% than you ought to be paying. These are meaningful dollars. So what can your organization do with aligning with a company like Renzo's and making that transition? What will that mean to your bottom line? Because remember, this is a top SG&A expense, typically number one after payroll. Any savings there drops directly to your bottom line. It's the creation of EBITDA. If you're charged with P&L responsibility, you have to pay attention to this stuff. So you have to ask yourself, does it make sense to keep doing what we're doing? Are those Super Bowl tickets, that my broker throws me enough for me to keep turning a blind eye to this? You know who you are. Or is there a better way? Should we be looking to partner with folks like Renzo? And Renzo, by the way, how do people find you?
Well, you can go to our website, USRxCare.com. That's probably the best way. You can get in contact with us there. If you're at conferences, I'm often on stage or on a panel. And if you see me, stop by afterwards and say hello. And we can schedule a virtual visit and educate you a little bit more on what we do. And to your point, most of our clients are seeing their per member per month drug spend drop by 40-50% in the first year.
Wow.
As high as 80%, right? And it just comes down to really two things: clinical rigor. And on that front, you go to a lot of conferences, I go to a lot of conferences, I hear a lot of people talk, and they say, you got to get the right drug at the right place at the right time to the right person, all of that. Right.
Yep.
We don't see a lot of that. We talked earlier on the GLP-1s and the CIV, which is the prior authorization process, if there's even a prior authorization being done at all.
Yeah.
Whereas we're looking at the medical record to make sure that the patient does have diabetes. What's their hemoglobin A1C? If it's 6, that's close to normal. They probably shouldn't be on a GLP-1.
Right.
What other drugs have been tried and failed? The clinical rigor, the getting the drug right. I'm going to give you a few examples that we've seen in the last couple of years that highlight the importance of clinical management, because this is probably the hardest thing for individuals to get their head around. It's easy to look at discounts and rebates because it's measurable, but clinical management, what does that really mean?
And before you, I want you to expand on that, but I have a couple of questions about clinical management. So question one is, are you the end all that be all? In other words, if your team determines that it's not medically necessary, can the patient still get the drug? That's one question. Another question with respect to clinical management, having nothing at all to do with money or access, how often do you find that let's say chemotherapy drugs are incorrectly prescribed or things of that nature? If you can address those two things, I think it'd be helpful.
Sure. So when we take on a new group, we find at least 20 to 30% of what I'll call medication errors, which means
Air quotes for those of you that are
errors.
listening.
The patient's on a drug for a condition they don't have. The patient's on a drug at the wrong dose. They went from 0 to 1,000 without stopping at stage 1 in terms of whatever is a first line therapy, right? Let me give you some examples. So in the last 2 years, we have seen 4 Strensiq patients. Strensiq is a drug that is for a rare genetically based bone condition.
Oof.
Also impacts their teeth. You see a lot of bone breaks. You see weak teeth. Juvenile onset, typically. 4 cases, all of them adults on the drug called Strensiq. Average cost of the plan per member was $2 million.
Oh, my God.
Okay. We asked for a copy of the medical
Who
record.
came up with the term Strensiq? It sounds like a French dessert. For tonight,
Would you like some
after dinner, we have the cheese plate or the Strensiq.
Funny. I never thought of that. Anyway, so we
$2
asked
million
for a copy of the
drug.
medical record, right? And there were certain tests that should have been done, had not been done. We asked for the tests to be done. And it came back that not one of those individuals had the condition, not one. Now, I can't tell you what they didn't
have the condition for, did you say a $2 million drug?
$2 million drug.
Holy shit.
Not one of them had the condition. So, of course, we took them off the drug. Right now, I can't tell you what they had. That I don't know, but they didn't have that condition.
Right.
Right. It's not uncommon. There, another case like this was one that was near and dear to my heart because this was an employer group that I helped bring in. And we went through great pains on implementation to neutralize any formulary differences, pharmacy differences, through a term called grandfathering, right? Allow folks to continue to get what they were getting on the prior plan to ease the transition. And smoothest transition in the history of transitions. 2 weeks in, the VP of sales contacted HR contacted the broker contacted our client services team, and they called me. And the VP of sales was screaming that we were asking the pediatric endocrinologist for his son to lower the dose of growth hormone by 40%.
I thought he was upset because you became the number 1 revenue generator for the company and
right.
was stealing his thunder.
Not yet. Yes.
Okay.
Living for what we do. I'm like, ooh, wow.
Yeah, that's a tough call to get.
Our team did a peer-to-peer with that doctor. We do a lot of peer-to-peers. Often it's just a matter of education.
What's a peer-to-peer? Am I a sailor? What's peer-to-peer? What does that mean?
What is a peer-to-peer? Meaning we have doctor to doctor.
Doctors talking.
Doctors talking to doctors.
So just say that, Renzo. Say their doctor, talk to our doctor.
Talking to the experts.
Excellent.
Right?
Got it. Now I'm with you.
And I'm talking over the case. And what we found out was that pediatric endocrinologist was dosing this child's medication. It was weight-based, based on another manufacturer's product.
Oh, great.
Okay. The two kind of sounded somewhat similar.
Uh-huh.
So the dose that he was prescribing was the correct dose for a different drug.
Right.
Okay? And we looked at the package insert. We looked at the medical record. We looked at we could not figure out how is it possible that this doctor could have this child on a dose that was that high.
Right. So this reminds me of a story, and I feel compelled to share it. So one of my children, I'm not even going to say which one, goes to a gas station and leaves the gas station and tells me, Dad, and I'm like, yeah, my car is acting really funny and it's shaking and shuddering and, you know, I'm stuck. I'm stuck. And I said, well, what happened? I said, did you do anything? No. I said, well, where were you before that? She said, I was at the gas station. I said, okay. And you put gas in the car? I said, what kind of gas did you put in the car? She said, you know, just gas. Oh. She put diesel fuel in a gasoline engine.
I didn't even think you could do that.
It's hard to do. Renzo, it's hard to do.
But it can happen.
And when you put diesel in a gasoline engine, you know what happens? It breaks. It doesn't work. And so what you're describing calls that to mind, except we're talking about a child, right? And so you're talking about a child that overdosed because a doctor got it wrong.
The doctor made a mistake, and they're
they're human beings, right? It happens.
But you know, at the end of the day, and I remember I'd sit up front. I spent a year in medical school, right? And it's a big responsibility. And medicine is moving so fast, and you've got to see 40, 50, 60 patients a day. You can't keep track of everything, right? And they're human. So the doctor made a mistake. So the dose came down. Plan saved about $40,000, and now the kid's on the right dose. I'll give you one other example. And by the way, all of these examples have one common theme. They were approved through a prior authorization process by the prior PBM, and the prior PBM was dispensing them. So
a PBM that's a mainstream PBM,
PBM that profits off of the dispensing of these medications, because these particular medications had to be dispensed by the PBM specialty pharmacy. Right. So if I'm looking at a potential $2 million drug, how diligent am I going to be to see if it's appropriate or not? Potentially not as diligent as I maybe could be or should be. All I can tell you in those 4 cases is Strensiq, they had been approved under prior authorization, dispensed by the PBM, and those individuals didn't even have the disease. The 40% overdose on the growth hormone, approved by the PBM, and dispensed by the PBM specialty pharmacy. One other case that maybe shows some creativity, but again, this is the kind of thing that you wouldn't get from a traditional PBM that at the end of the day profits off of the dispensing. So there was a case that we inherited. A child was taking a suspension, a liquid form of a particular drug. Cost of the plan, $46,000 a year. That particular drug, the same active ingredient, also comes in a pill for less than $100. So we called up the household and spoke to the mom and said, "Hey, can your 8-year-old son take pills?" She said, "Absolutely." So we switched from the liquid to the pill and saved the plan $46,000 a year.
Wow.
Who had approved the suspension, the oral form? The prior PBM. Who was dispensing it? The PBM.
Of course.
Right? I mean, so you do have the proverbial fox watching the hen house, right? And employers, and like I was talking before, there's the number one thing you can do is deconflict your PBM relationship. All of these things that we're talking about that impacts the clinical decision making, it impacts the formulary, it impacts the treatment guidelines. All of those conflicts of interest have an impact on diluting the efficacy of all these tools that are in place to protect the plan sponsor, right? And why would all of those things get diluted? Because if they were acting the way they were, you would limit the revenue and profitability of the PBM, right? So you have to either replace your PBM with a fiduciary PBM. And I go to fiduciary. Transparency is not enough.
Sure.
Fiduciary covers that plus those other two.
You've taught us that today.
Or if you feel that you can't leave your PBM or you're locked into a long-term contract, at least take those clinical functions and move them to an independent third party. And we provide those services as USRx Care also. We have hundreds of thousands of employers' lives where we're doing the prior authorization, not the PBM.
Are those contracts easy to break? You know, I hear often, oh, we're in a 2-year contract, we're in a 3-year contract.
Unfortunately, many have some significant penalties if you want to get out early. So often not so much. We wouldn't recommend anybody sign a PBM contract longer than a year.
Right.
And
why
ask
would you?
90 day out. Even if you have to give up some of the guarantees along the way, just make sure you get all your rebates.
Yep.
Regardless, because that's a common tactic. If you want to leave early, you lose all your rebates.
Right.
Don't sign any of those sorts of contracts. And oh, by the way, we talked a little bit up front about the Consolidated Appropriations Act, right?
Yeah.
It's a gift to employers in that it puts power in the hands of employers in terms of getting transparency, not only from their PBM, but also from their broker advisors, so they can see all sources of revenue.
Mm-hmm.
But part of the CAA now is employers have to attest at the end of every year that they're living up to their fiduciary duty.
Yeah.
Right. So the Department of Labor is putting fiduciary front and center. They're really putting the onus on the employers to ensure that they're living up to their duty. I would say in the past, that level of focus on the employer's duty hasn't been front and center. Now it is. And what does
Yeah.
that mean? That the stakes are higher than ever in terms of who you hire to manage your benefits, whether it's a blues plan, a TPA, a PBM. Isn't it easier to hire an entity that's administering your benefits that has the same fiduciary obligation in their contract that you have as an employer to the Department of Labor? Frankly, I've struggled to understand in the context of the CA, because now, I mean, we saw the J&J lawsuit, right?
Yeah.
Johnson & Johnson is being sued for having hired a PBM that was overcharging on prescription medications, marking them up thousands of percent.
Sure.
Right? And who did they hold accountable? The employer, not the PBM, because it's the Department of Labor. Department of Labor doesn't oversee the PBM industry, but they do oversee ERISA, right? So they held the employer. So now employers are accountable for their fiduciary duty. To me, it makes a lot more sense to hire a PBM, a TPA, a carrier that puts fiduciary language in their contract and holds themselves accountable to that standard, as opposed to hiring an entity that puts language in their contract that says they're not a fiduciary and not obligated to act in a fiduciary manner. How at the end of the year do you attest to the Department of Labor that you're living up to your fiduciary duty if you'd hired entities to manage your benefit that have no fiduciary responsibility whatsoever? I'm not sure. And I guess the markets will decide.
Yeah. I don't think I could articulate it much better than that. It just makes, crystal clear sense to me. And, for those not in the know, the CAA and the Consolidated Appropriations Act, what it really has baked in now is an attempt to, not an attempt, it's now law that employers must spend planned dollars wisely. It puts healthcare on the same footing as your 401k or your 403b. It's the same. Why should it be any different, right? When employees are footing their share of the cost for healthcare and the employer is charged with spending those dollars, isn't it appropriate that the employer be held to, the utmost scrutiny with respect to how those dollars are spent? And what you're saying, Renzo, makes perfect sense to me. Like, why would, if you now know that it's the law of the land and you're obligated to the DOL, why would you sign a contract with someone that isn't willing to be a fiduciary? That seems pretty basic to me.
Yes,
Right?
100%. But, it takes time. And more, thankfully, are asking the question. You mentioned the member, and we often focus on plan dollars, right? But the reality is, and we've proven it over and over and over again, if we are reducing the plan spend per member per month by 40%, let's say, the average member is spending 30% less on their drugs. They run together.
Sure.
Right? Because good clinical management, and the other part that we haven't really focused on is the sourcing. At the end of the day, you want to make sure that you're getting the needed medications at the lowest available cost.
Mm-hmm.
Right? And what does that mean? You don't want to get into a contract that locks you into only using the PBM-owned pharmacies, right? Because now you can't shop, right? You're locked in. Whether it's a good price or not, it doesn't matter. You have to use their pharmacy, right? So you want to have choice. We have 14 specialty pharmacies in our network. We pick for each individual drug, we pick the pharmacy that has the best contract price for that drug. If you're locked into the one PBM pharmacy, you don't have the ability to do that. We send generic specialty drugs to retail pharmacies. Why? Because it's a lower cost environment. You can get a better price. Again, if you're locked into your PBM, you have to use their specialty pharmacy. You don't have that option, right?
So what I'm hearing is you're really giving ultimate flexibility to your clients. You're giving them freedom of choice, and you're not pigeonholing them into going here or going there or being strapped with this provider or that provider, with this drug or that drug at this price or that price. You're basically using your expertise to deliver the appropriate medication, and you know it's appropriate because you have a clinical team that is there doing the checks and balances at the best price ultimately to the plan and the member.
100%. And again, at the end of the day, we find that members are spending 30, 40, 50% less for their drugs. There's that much waste in the system,
yeah.
But also a lot of it comes down to education. We spend a lot of time educating members and doctors about the cost of medications.
Yeah.
Right. And the fact that there are multiple options. Again, I spent time in medical school. A doctor prescribes a drug and the patient thinks that the doctor has exhausted the entire list of pharmaceuticals in the world and decided that this is the one drug that is going to help them.
Right.
When the reality is there might be 14 drugs that work exactly the same way, and why the doctor picked that one today, who knows? It could have been that they had a good meeting with the drug rep.
Right.
Sure.
Sure.
So what we do is, at the end of the day, we spend a lot of time with doctors and members rationalizing the medications, looking carefully at options, and making sure that the where there are therapeutic equivalents, that the lower cost option is considered. That being said, I want to mention one other thing, because the fear factor amongst HR is real.
Yeah.
I'm afraid of change, right?
Sure.
I know my costs keep going up, and I know there's probably a better option, but I'm afraid if I change, everything's going to come crashing down. Or if I chase 40, 50% cost savings, I'm going to have a line out my door of complaints, right? The reality is that when you move in a fiduciary direction and you eliminate all the conflicts of interest, you have more flexibility, actually. You have more pharmacy options. You don't have to go to just one. You have more flexibility with the formulary to make changes. When we do an implementation, for example, we look at the difference between our formulary and the previous formulary, and we have a discussion with the client. If you want, we can take all these drugs that we have in tier 3 and we can move them to tier 2 where they were before. It's your plan.
Yeah.
We don't cover these drugs, and here's the reasons why. But if you want to cover them, we'll add them to the formulary. It's your plan. Good luck having that conversation with a traditional PBM, right? You can't get them to change one thing on the formulary, and if you ask them to do that, they may charge you a custom fee,
right?
And they may remove other guarantees.
Yeah, and you mentioned Humira before, and you said it was, I think, a $60,000 drug, but it depends, right? There are some charlatans out there that'll charge north of $60,000, $90,000, $100,000 for the same exact drug. It's crazy. I should also mention to folks that you and I, I'm a producer of a documentary film that you actually are a participant in, and it is available. Actually, anybody could contact us and we'll share the link with you, but it's not personal. It's just healthcare. And you should be very proud of the work that you did there, Renzo. I thought you were excellent. You actually see Renzo pulling out some contracts and shaking his head saying, "Can you believe this stuff?" It's great, but
it is hard to believe. That's why we got into this, right?
Yeah.
Because we saw the industry going in completely the wrong direction. And it's making our employers less competitive on the global stage. So
100%.
We're saving individuals in their pocketbook.
Let me ask you this.
In some ways, we're saving the U.S. industry.
Of the major insurance carriers, are there do you have clients that have UMR and Cigna and these other BUCA networks on their plan? Are there some where yes, you can be, and others that don't play nice in the sandbox and say no, it's our way or the highway? How does that work? Maybe I'm an employer that is eating this up with a spoon, and they're buying into everything that we're saying, because after all, I think you're speaking the truth. I know I'm speaking the truth, and I know you're speaking the truth, but it might be hard for people to digest. But if you're in a market where you're kind of cornered, and there's this, hospital and that hospital, and you're like, oh, if I want to break away from United or Cigna, it's gonna be an uphill battle, and I don't know that I have the appetite for it. Is it possible to have USRx Care run side by side with these folks?
Yes, and in two ways. We have many clients that use Abuka for their medical network,
Okay.
right? We have clients, as I mentioned before, where we're not adjudicating claims, we're not processing claims, we're not the PBM, but we're providing the prior authorization service to get the fox out of the hen house, right? I mean, if they are making profits off of the dispensing, it makes sense that they shouldn't also be the one to decide what to dispense. Right? So we're providing the prior authorization. So that's another way of doing it. To your point, there are some plans that will restrict if you have less than 500 lives, less than 750 lives. I've heard upwards of 1,000 lives, and you want to use the network of the health plan. You also have to use their PBM, right?
Right.
My statement there is run, right? Because they're requiring it for a reason,
Right.
right? They're looking to double dip.
Yeah.
So if that is the quid pro quo, look for a different option. There's so many excellent TPAs out there. Many of those TPAs have access to the Aetna network, the Cigna network, the United network, but you're working with an independent third party, right? A buffer, if you will, where you can have an entity that is truly looking out for your best interests at all times. Right?
Excellent.
So 100%, you can deconflict your PBM relationship in many ways. One is to change the PBM. The other is to outsource some of the functions, particularly the clinical management. You could do the same thing on the medical side, right? You could use a carrier's network and have an independent entity doing pre-certs, right? An independent medical management firm, right? It's important to separate the profiteering from the clinical decision, right? Let them adjudicate the claims. Let them negotiate the best price. Let them negotiate the best rebates. Make sure you as a plan sponsor get 100% of the discounts and 100%, not just the rebate, any manufacturer money. So that's a common trick in the business, right? We'll give you 100% of rebates.
Yep.
Well, a rebate may be half of the money that comes from the manufacturer to the PBM. The rest of it's not called a rebate, so you don't get to participate in that. But that additional money is still incentivizing the PBM to do things that may not be in the best interest.
Well, isn't that just special?
Isn't it? There's a million. It's the shell game times
Right.
times 5. So the
Unbelievable.
best way to save your plan and save your future, frankly, is just to move in a different direction, and then like what we've talked about.
So what I'm hearing is there's more than one way to engage your services. I think it starts with a good benefits healthcare consultant advisory firm, but certainly if you're hearing this and you are an employer that's just kind of looking for answers and you want to get on the path to, hey, how am I doing? Because I do think it's important that you take the temperature every once in a while for all of your vendor relationships. I think it's good to hold, folks accountable. This isn't infidelity. We're not talking about cheating on anybody. We're just saying, hey, I'm obligated to, put my finger on the pulse of the market and see how we're doing. Contact Renzo, contact the folks at USRx Care, and take a look. See if you can do better, and see maybe. If you can engage all of their services, maybe there's a carve out. Maybe there is a way to engage their services and get your plan on track to better health care for your members. Because while dollars and cents is certainly front and center, nothing is more important than the health of your people. And getting the right clinical management in line, to me, just makes perfect sense. It's something that I think is a more moral, ethical obligation as an employer that we all owe our employees. So
right, and at the end of the day, we've shown time and time again, and I shared some of those egregious examples where
Yeah.
there was high spend and folks were on drugs to treat diseases they don't even have, right?
Yeah.
That is not good quality healthcare, right? And there is this myth that the more
Despite the logo on your ID card.
right, that the more you spend, the better.
Yeah.
We've shown time and time again in terms of the good clinical management, digging into the medical record, getting it right, communicating with the doctors, having doctors talk to doctors and pharmacists talk to patients, helps us navigate to a better place where the outcomes are better. People are on the right drugs. They're not on the wrong drugs. Drugs come with side effects, right?
Yeah.
So
Yeah.
if we can prevent someone from going on a drug that they shouldn't go on just because we've taken the time to do some additional investigation. And I'm not talking about delaying care. It doesn't take that long.
Yeah.
You end up with better outcomes and you end up at lower cost, right? So the two really do go hand in hand. And it does not have to be disruptive. We wouldn't have 5 million lives as a company if there was a line at HR,
Yeah.
right? We have very little turnover, very little. As a matter of fact, from a broker community, what we find is once they've placed one group with us, they place all their groups with us.
Yeah.
None of those employers would go back to the traditional model. It's too scary,
Yeah.
right? They have more transparency. They know more about the drugs that are valued and not valued. They trust that when someone is on a high cost drug, it's for the right reasons, not for the wrong reasons.
Sure.
And their per member per month cost is half of what it was before, and then maintained flat for
Sure.
years, right?
Well,
We
sure.
back the clock 5 years.
You're
or more.
getting you're delivering the same exact thing at a higher level of service most often at a greatly reduced cost. That's a recipe for repeat business. No one's going to go back to the old. We understand that, there's FUD, there's fear, uncertainty, doubt. People are afraid they're afraid of change. This is human nature. It's not just HR, it's leadership, it's people, it's everybody. But once you make that move and you take that step and you realize, what the hell was I doing until now? You're not going to go back.
Never.
Renzo, I really appreciate you coming on and sharing your story and really giving us an education as to what you do and what is possible. Don't take my word for it. Take the test. Take a look at what you're spending on drugs today. Reach out to the good folks at USRx Care. Have them do a comparison for you and see how you're doing. And if you're doing great, if you're doing better than they could do for you, then guess what? Check that box. You're doing fine.
100.
Right? And if not, maybe think about changing. So that's it, folks.
So much, and we appreciate the platform. And I want to thank you for everything that you do, because we really are on this mission together, and we view it as a mission.
Yeah.
Right. And it is so much fun, and it's so rewarding when we're a year in with an employer and they're saying, "Wow, we've saved so much money. What would it cost us if we waived deductibles on all mental health drugs?" Wow, we've saved so much money. What if we waived deductibles on diabetes medications? And usually the answer is it'll drive up your costs a little bit, but it's not going to erase the 50% reduction that we achieved in the first year. So now they're actually able to enrich their benefit on the back of the savings. And the other thing is inevitably there's going to be a high cost claim.
Yeah.
Right. And it's appropriate. It's the right thing from a healthcare perspective, because at the end of the day, good quality healthcare comes first. Cost
100%. Yeah.
Right. Because this is a health plan. This is all about healthcare. But if your costs are running half of where they used to be year after year after year, you're much better prepared to deal with that inevitable high cost claim.
No question, and it's counterintuitive, but in healthcare, cost and quality are inversely proportionate to what you would normally think, right? The highest cost in healthcare is typically the lowest quality, and the lowest cost is typically the highest quality. And that's just the way that it works. It's counterintuitive, but it is fact, and you don't have to take my word for it. Google it, go out there and look at medical doctors like the great Dr. Marty McCary, who wrote The Price We Pay. He spells it out in black and white. He's not a healthcare insurance professional. He's an actual medical doctor. There's a ton of resources out there for you to fact check us. But what I love about what you do, Renzo, is it's black and white. Here's what you paid. Here's what it would have cost. Do the addition, do the subtraction. There's the net that could drop straight to your bottom line. So listen, my friend.
Easy math.
You've been an awesome guest. Appreciate your time. Folks, that's all we got for today. Thank you for tuning in, and we will see you on the next one. Peace.
So that's it for today's episode of Broken Healthcare. Head on over to iTunes or wherever you listen and subscribe to the show. One lucky listener every single week who posts a review on iTunes will win a chance in the grand prize drawing to win a $15,000 value private VIP day with Ray Kober himself. Be sure to head on over to brokenhealthcarepodcast.com and pick up a free copy of Ray's gift and join us on the next episode.